Good afternoon, ladies and gentlemen. It's a pleasure for me to be here. This is my home branch, so I am working at home and I am the members of Drkdnayar and of course there are other members also who come from other branches. The topic is what is new in male infertility. As per the Lancet report of 2021, 1 in 6 or 1 in 7 people is having infertility, and male factor being primary or contributing cause in almost 50%. The important thing is fertility rate in men younger than 30 years is also decreasing. This is the finding. Whenever we go into other meetings also, the total fertility rate is now decreasing. It is, in many states it is almost 1.9. The figure of 2 has to be there so that it can be birth can be added. So with the 1.9 figure, we are going to have a decrease in the population in future. So we see the fertility rate also decreasing in males younger than 30 years. 25% of the infertility cases, no detectable cause are there, they are unexplained, and multitude of causes and factors contribute to this increasing incidence of male infertility. A systemically reported sperm count decreased by 50 to 60% between 1973 to 2001. I still remember when I was a medical student in 1971 to 75, I was an MBBS student. That time we were taught by our professor the normal sperm count is 60 to 120 million. Subsequently, it has come down to 20 to 60 million or 40 to 80 million. That is the sperm count in the generation after me, who are now 40 years plus. Thereafter, it has now come down to see the new WHO criteria. Even 50 million is also accepted as a normal. So the count is decreasing. 15.4% have increased risk of they are suggestive of pre-diabetes, and which is also a cause of hypogonadism, higher DNA fragmentation. Obesity is also seen, and men who are ageospermic, they also have high incidence of metabolic syndrome. This is the infertility cases per region all over the world. You see at this figure, very clear in all the Middle East and Asia, almost 60 to 70% of the patient having a male factor infertility. Male factor is a complex process. What is needed? A man must produce healthy sperm. The sperm has to be carried in the semen, and there need to be enough sperm in the semen, and finally the sperm has to be functional and able to move. All these 4 factors are needed for a man to be capable of producing children. And what are the causes of male fertility? Either it can be hormonal, or man can have a varicocele, or it can be genetic. Important factor is the lifestyle factor, and in 50% of the patients we don't know what is the cause, so we label it as idiopathic. Idiopathic risk factor, 40 to 50%, these are the causes: smoking, alcohol, recreational drug, obesity, psychological stress, advanced paternal age, dietary factor, and environmental exposure to toxins. The lifestyle management, you have to have a reduction in weight when the patient is obese, decrease alcohol and smoking, use fitted undergarment, avoid occupational exposure to heat, frequent sauna bath, avoid anabolic steroid, control diabetes. Smoking, we all know men who smoke also have a decreased measure of sperm quality, including decreased sperm count, and motility and morphology to normal sperm. And the side effect of smoking and recreational use. Smoking is associated with reduced sperm motility, and recreational drugs like anabolic steroid and marijuana are also associated with impaired sperm function and production. When we look at current younger generation, we see a lot of young men with 6 apps. This is 6 apps picture, and what they are doing is they are taking hormonal tablets, testosterone tablets when they are going to gym. They have a lot of powders helping them. The gym trainer will tell you take this powder that will help you to make 6 abs. When you have a 6 abs, your sperm count becomes 0. That is the problem. Alcohol, all of us know high amount of alcohol can have a systemic increase oxidative stress. Obesity is also clearly linked, and one must take a lot of antioxidants which are available there in fruits, and vegetables, which can help us in improving the oxidative stress. The boxer short, the brief underwear which is available these days, can also raise the temperature of testes. Can raise the temperature of scrotum and testes. So choosing a boxer's underwear which was in an old-fashioned one, that is going to avoid this increase in the testicular temperature. And one must avoid like hot tubs, laptop on the lap. All these things can increase the testicular temperature and it can affect the sperm quality and quality. How often a couple should have intercourse? Believe me, I am a practicing IVF. Many times I see young couple working in MNC, coming for infertility, and when I ask them how many times they have contact, they say once in a month. That is with the young educated people also. They have to be told that they should have intercourse at least 2 to 3 times a week during the fertile period. Give them a fertile period window, 1 week. They should have contact every alternate day. That is the way to achieve a pregnancy. And they have to be told. They say, I am on day duty, she is on night duty, or vice versa. We have no time. We have no thinking of having a contact. You have to, until you have contact, you cannot produce baby. I think coital practices can improve your chances. The sperm which is ejaculated to vagina will reach fallopian tube within minutes, regardless of position during intercourse. So their fixation, this position, that position, no. The sperm which are ejaculated can reach fallopian tube within minutes, and the use of lubricant has to be avoided because lubricants can slow down the sperm and decrease the ability to survive. The only lubricant which is approved is canola or baby oil for pre-seed fertility lubricant, which is available abroad. I don't know if it is available here or not. Falling testosterone age, you see, when we were a young boy, we always used to say, man and lion never gets old, but look at the figure. By the time when reaches 40 years, his testosterone will be half of what it was in the 20s. At the age of 50, the testosterone level will be 1/3. At the age of 60, it will be 1/4. So there is a marked reduction in testosterone, and what it does, it set onset of degenerative changes like heart disease, arthritis, obesity, high blood pressure, adult onset diabetes and cancer, along with a fall in the sperm count, and this can be reflected in the progeny, the babies conceived by an older man. What is the age of effect of age? That is now very well documented. If the husband is of older age, that is going to affect the progeny, next progeny. The link between impairment of glucose and male fertility. I talked about pre-diabetes and diabetes. The impact of diabetes on sperm quality can be there. There can be decrease, progressive mortality, increase DNA fragmentation, negative effect on male fertility, also because of reducing sperm count and DNA integrity, pathophysiology of diabetes and male. There is alteration in the testicular environment, testicular hemostasis, ejaculatory function, libido, and sexual dysfunction like erectile dysfunction. All these things happen when the man is pre-diabetes or having impaired glucose. You can have all these issues, and that is affecting the fertility. Similarly, the metabolic syndrome and male fertility. Metabolic syndrome has also effect on the male fertility. When the man is having metabolic syndrome, it will reduce the testosterone level and increase the estrogen level in the body and increase the oxidative stress. And there is chronic inflammatory situation which is associated with metabolic syndrome, insulin resistance, lifestyle factor. All these factors contribute to the male fertility, in fact impacting the fertility of the man. When a couple come to us when we want to investigate for the male factor, the basic investigation is standard semen analysis. This is what we ask for it. And in semen analysis, what we are looking for it? We are looking for sperm count, we are looking for sperm morphology, and sperm motility. These are the three factors we are looking for. The type of male fertility, it is very clear that either it can be qualitative, probably people connote upper one is qualitative, or it can be quantitative. It can be endospermia, oligospermia, estenodospermia, or tetraspermia. That is the terminology to describe the sperm pathology, either oligospermia, that is decreased number, less than 50 million, estenodospermia, at least 30% sperm should have progressive motility. Tetraspermia is the motility, the morphology, less than 4%. This is the distribution of male, infertile male, depending upon what type of the pathology they are having in the semen. Estenodospermia, estenodospermia, endospermia. If you look at it, the biggest is estenodospermia and endospermia, almost 21%. This is semen analysis, WHO 2021. This is the benchmark these days. We have to have sperm concentration of 60 million per ml, a motility of 42%, out of which 32% must be progressive motile. And if the semen analysis fit into this criteria, we really don't have to repeat it. If the semen concentration less than this, then we can repeat the test even after 2-3 days. Once you do a semen, when you collect the semen, what laboratory investigation you can do? Either you can do a macroscopic check for the volume and pH, you can do a microscopic check for the semen concentration, motility and morphology, and sometimes you go for advanced tests like reactive oxygen species, sperm DNA fragmentation, nucleides, and mitochondrial function. These advanced tests generally we are not doing. Overview of spermatogenesis, I just want to give you an overview that the mature spermatids are released from the Sartori cell and they enter the epididymis. Once they enter the epididymis, during the passage through the epididymis, the spermatid undergo biochemical changes, activation, and they become capable of fertilization. This procedure is called capacitation. This is important because this is going to be one of the causes for the male infertility. The male subfertility present either with decreased spermatogenesis or oligospermia, estenodospermia, tetraspermia, or low capacitation. What I mentioned, discussed about the capacitation. If the capacitation low, that can also present with the male infertility. The current treatment approach focuses on improving morphology, motility, and count of sperms. Again, going back to the male subfertility, either it can be a decreased spermatogenesis, or there can be increased abnormal form, or decapacitation. Like I mentioned, for decapacitation, the sperm need energy to be activated, and that is coming from ATP from the mitochondrial, which are present in the midpiece. The goal of treatment, either we must improve the spermatogenesis, maintaining optimal level of testosterone, reducing oxidative stress, increasing sperm count. We must improve the maturation, increase number of sperm with high mitochondrial potential, reduce sperm DNA damage, reduce the amorphous substance, and we must improve the capacitation, increasing mitochondrial potential, felicitate acromosal reaction, and increasing sperm motility. That is the aim for our treating infertile male. Spermatogenesis, increase maturation, increase capacitation. The worldwide incidence of male oxidative stress. Everybody is talking about male oxidative stress. When we look at this study which was presented in 2019 by Dr. Agarwal from Cleveland Clinic, he calculated that the oxidative stress is almost there in 30 to 40% of the men who have a known or unexplained cause. And when you have idiopathic cause, almost 80% of the men will have oxidative stress. So this concept of oxidative stress infertility mostly has been proposed and pointed out about 30 to 80% infertile men can have increased reactive oxygen species, which will affect almost 37.2 million infertile men. This is the role of oxidative stress in male infertility. If you look at it, if you have an oxidative stress, it is affecting capacitation, it is affecting acrosomal reaction, hyperactivation, you can have leukocyte in the semen, and you can have direct addition and production of soluble factor that alters sperm quality. The oxidative stress is causing damage. Either it can cause a DNA damage to the sperm, it can do a lipid peroxidation, or it can do a protein damage. These are the three ways the oxidative stress is affecting the sperm function. This is the balance, oxidative stress balance: idiopathic, lifestyle, environmental, iatrogenic infection, autoimmune, chronic, and again either damage to the sperm DNA or damage to the membrane. Now, what is the therapeutic management of male factor? How we should go about it? Either we should give them hormonal agent like testosterone, or anti-estrogen like clomiphen, or aromatase inhibitor like letrozole, or we can give them HMG or SCG. That is a hormonal agent to increase the level of testosterone or FHS LH being produced by the pituitary. Or we can give them antioxidant, which are glutamine, lycopene, vitamin E and C, and N-acetylcysteine. Or we can have a sperm vitalizer like L-carnitine, CoQ10, myoinositol. And we can have nutritional supplement like zinc, folic acid, selenium, and miscellaneous like endocytosin, L-arginine. Role of antioxidant, that is a drug which is most abused these days. Everybody is writing left and right antioxidant. Some people even don't know the doses. They are giving a very high dose for a long period of time. Let us see, if you want to use antioxidant, how you should go about it. Any drug for given for male fertility, you have to give for 3 months, 3 to 6 months, not more than that. And the dose has to be as per the compound which you are using it. These are the brands available in Indian market. If you look at it, most of the brands are having a combination of astaxanthin, CoQ10, zinc, L-carnitine, lycopene, selenium. And in this, CoQ10 is the most expensive constituent of this combination. The brands are, I already mentioned that different companies have different brands. 2 new brands have come, this Sperm and anabolic. Anabolic MP is having myoinositol plus N-acetylcysteine. The myoinositol is also there in other compound. So, because generally till now we had never been thinking of giving myoinositol to male person, and the use of N-acetylcysteine was also, when I read initially it was for the female fertility, but now we are giving for male fertility also. Let us see how they can be used. This is the nutritional intervention which we do, where it acts. All the drug doesn't act on whole of sperm. They are basically acting at the sperm head, which contain DNA, like vitamin C, E, lycopene, N-acetylcysteine, and L-arginine, L-carnitine, CoQ10 are acting on the midpiece, and zinc, selenium are acting on the tail of the sperm. CoQ10 I mentioned, this is most expensive component of all the combinations which are available to us. It is concentrated in the mitochondrial midpiece, and it is involved in the energy production. That is important. It is involved in the energy production. It improves sperm motility and count. If you look at the midpiece, that is where mitochondria are arranged. But you have to remember, the CoQ10 is available in oxidized form and reduced form. Ubiquinol is the reduced form, which is active, and 70% is bioavailable. That is what we are, when we want to do CoQ10, we should be using the drug which has ubiquinol. N-acetylcysteine, like I mentioned, we read about it for the female fertility. Now it is coming to male fertility because it promotes cellular glutathione production and prevent oxidative mediated tissue damage. There is a combination of selenium and N-acetylcysteine, N-acetylcysteine, and adequate intake, and it cannot be obtained through the dietary intake, so you have to take supplement. And the literature supports the role of NAC in treating idiopathic cold. You can give a dose of 600 to 1200 milligram. Myoinositol, this is basically belong to vitamin B category, and it is from the nature 99% is myoinositol and 1% dichloroinositol. It is acting on reproduction and fertility. It regulates the activity of FSH, LH, and EBIL, maintains osmotic environment of sperm maturation, inhibits sperm DNA fragmentation, and reduces amorphous substance in the seminal fluid. and increase in influx of calcium in mitochondria, thereby helping in energy production. Antioxidant, I've discussed so many antioxidants. In male subfertility, this was a publication, Cochrane 2014. This was updated. Initially it was presented in 2011. 2014 they presented updated. 14 are randomized controlled trial. 4,179 patients were included. And they found that a live birth rate was slightly increased, and similarly clinical pregnancy rate may have increased when you are using the antioxidant. But all this is a low quality evidence only from 4 randomized controlled trial. Out of 48 randomized controlled trial, only 4 showed a low quality evidence that it includes the live birth rate and clinical pregnancy rate. Why I am presenting this? Because when we are writing antioxidant left right to our patient, probably we should be able to discuss with them also that this evidence belongs to a low quality evidence. There is still no paper, no publication will say that the antioxidant will do the job immediately. You have to give for 3 to 6 months, and you have to wait whether there is going to be positive effect or not. You should be able to tell the patient. How can I improve our chances of getting pregnant? You should maintain an ideal weight, antioxidants like fruits and vegetables, reducing stress, controlling chronic medical disease like blood pressure and diabetes, and all the changes. You have to remember, any changes in the man lifestyle will take almost 3 months to show an improvement in the sperm. You have to wait for 3 months. Nutritional play a vital role. It is involved in successful maturation sperm, provide nutrition for motility, improvement in sperm count and motility, help in production of sex hormone, and prevent sperm damage. What is the need of hour? Currently the need of hour is an holistic approach to the management, clinically studied combination. There are different combinations available, so we have to change, you have to invent more combination. Data on idiopathic patients who are having idiopathic issue, how they can be treated, and data on reducing DNA damage. That is important thing. Whatever we do, we have to reduce the sperm DNA damage. Only then the male factor will improve. Vision for the future. There is evidence in literature for the beneficial effect of antioxidant. Like I mentioned, 4 studies showed low quality evidence. And the current ongoing trial will provide answer to the safety and effectiveness of antioxidant. That is important. We are giving antioxidant left and right. We have to see what is the safety level of these drugs. Drug which patient is taking now, maybe for 6 months, maybe after 1 year, the patient may have a serious different side effect. So we should try to find out what is the safety profile of these drugs and effectiveness. And further studies are needed to, if we give antioxidant, can the antioxidant prevent fetal development defect in high-risk pregnancy with diabetes? If that can happen, that will be another advantage to us, that in a such patient with high-risk pregnancy, we can give antioxidant to prevent the development of side effects to the babies. Thank you very much. If you have any questions?
Thank you, sir. It was a very detailed description of the male factor infertility and the treatment. We have covered almost all the topics. Any questions from the audience? Yes, ma'am.
Sir, I want to know, sometimes we get that abnormal sperms are more in the semen analysis. So what is to be done if we get abnormal sperms in the count?
Morphology.
Yeah.
You're talking about
Like tail defect or head defect
yeah,
or mid-piece defect.
These are problems with the morphology.
Yeah. So what is to be done for that?
You have to repeat the test to come through by senior embryology who should be able to check it. And if you ask me honestly, right now there is only plethora of antioxidants which are available. Whether the antioxidant is going to correct the morphology or sperm, I also don't know. Maybe Dr. Sharma can give some answer.
Yeah, it is when we treat the male factor infertility. Remember, we are not treating the semen sample.